दरवाजा बंद कर दो। Good afternoon, everyone. I hope I'm audible.
Audible, sir.
Hmm. I know it is about 2-3 minutes more for being 2 p.m. We're just checking with the audio video if everyone are set to go. So YouTube is live now. YouTube link is live. Dr. Tanu.
Yes, sir. Yes, sir.
Okay. So good afternoon, all the officers of the states and the district health departments who have joined today, which is the repeat workshop of what we had yesterday. Workshop on clinical management of adult and pediatric cases for heat events during the summer of 2024. So program officers of the state and district health departments, colleagues from the National Program of Climate Change and Human Health, specialists from the various adult and the pediatric hospitals that have joined from across the country, medical officers working at the primary healthcare center, urban healthcare centers, CHCs, and various hospitals in the country, and others who would have joined today. Good afternoon and welcome to all of you to this webinar. This webinar is the second one. Yesterday we had the first to provide an opportunity of the people to have an interaction and opportunity if they for some reasons were not able to join yesterday. The outset, I would like to share the greetings from the Director General Health Services, Government of India, at whose initiative we are having this webinar. He would have loved to join, but he had to leave on an outstation tour. And myself, I am Dr. Akash Srivastava from the National Center of Disease Control. So I would like to, on his behalf, welcome you all to this webinar. You would all be aware that in the last 2 weeks, following the seasonal outlook that was released by the Indian Meteorological Department about the possibilities of increased frequencies and intensities of heat wave in various parts of the country in this summer season, there has been reviews undertaken of preparedness related to heat measures. None less than the Honorable Prime Minister himself, also the Honorable Union Minister of Health and Family Welfare, by the Honorable Member Secretary Niti Aayog of Health, by the Secretary Ministry of Health and Family Welfare, by the Secretary Ministry of Home Affairs, and by the Member Secretary NDMA. All of them at the individual level have undertaken separate reviews. And in all of these reviews, some of the salient points that has come out for the preparedness of the health sector, I would like to highlight some of the important points. The first foremost was that to ensure that health facilities and the ambulances are prepared and geared up for the season. It is expected that all the health facilities have either heat stroke beds or heat stroke rooms identified and provisioned for emergency cooling procedures. Health facility preparedness checklists have been prepared in this regard and has been circulated widely under the NPCCHH program. All health facilities across the country are requested to contact the NPCCHH officer of their district and state, get access to these checklists. It's an online checklist through a QR code. You can access the Google form where you will be taken through a 5-minute questionnaire where you can fill in what are your level of preparedness and also understand what is relevant for you to do during this season. Secondly, capacity building of the healthcare workforce, both the doctors as well as the paramedics and other important healthcare workforce that are relevant, including those who are working in the ambulances. And in this regard, this webinar would be a provisioning opportunity for all the specialists joining from across the country in adult medicine or pediatric medicine to understand what are the laid out diagnostics and treatment protocol for such cases who are affected by heat. In treatment protocols required to be displayed at the relevant patient care areas and essentially in all the places wherever heat stroke beds and heat stroke rooms have been stationed. Thirdly, improving the surveillance reporting of heat stroke cases and deaths from both the public and private facilities wherever qualified doctors are present. There is on the integrated health information platform a reporting surveillance mechanism under the NPCCHH program to report such cases on a daily basis, and all health facilities wherever doctors are stationed are requested to partake in this surveillance system. Fourthly, to ensure that there is a continuous dissemination of public awareness messages and a focus should be maintained for those who are vulnerable, especially vulnerable in context of either their demography or in context of their pre-existing health condition. Fifthly, ensure that the meetings under the district collectors of the district task force, which has been envisioned under the National Program on Climate Change and Human Health, do happen to review the preparedness at the district level, and the minutes of those meetings are shared with the national offices. And also to ensure that there is a continuous supply of electricity to the health facilities during the season. And one of the measures that are provided in the PIPs of NHM towards this purpose is putting up solar panels in health facilities wherever it is essential so that there is a continuous supply of energy. So, with all those points that have been repeatedly said again and again in these review meetings, I have tried to communicate them in my opening address. And I would like to introduce you to the two esteemed speakers who have been requested to make an address about the conditions of the adult medicine and pediatric medicine relevant to management of heat related cases. Dr. Sanjay Kumar, he is a professor medicine from Lady Hardinge Medical College of Delhi, and Colonel Dr. S.C. Shaw is a senior advisor in pediatrics from the Army's Research and Referral Hospital, Delhi. Both of them would be today making their address and providing you the details of how you can diagnose and manage such cases. With this, I would request Professor Dr. Sanjay Kumar to please initiate his talk. Dr. Sanjay Kumar, please. Dr. Tanu, is his connection working?
Yeah, he is connected. Dr. Sanjay
Okay.
Kumar, are you presenting something? Can you hear us?
Is he able to connect, or there is a problem?
We are seeing him. He is connected.
Sir, or else I can start in case he is having some problem.
Okay, so okay, he started sharing his screen.
Oh, no, he has started since.
Okay,
Yes,
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 yes.
yes.
Sir, request you to unmute, please.
Am I audible now?
Yes, yes, you are talking.
Uh, Thank you, everyone, and welcome to this webinar on which I'll be looking at the heat-related illnesses in the management aspect and the mainly the adult uh, part, and Dr. Colonel will be looking at uh, the pediatric group. So, is my screen visible to you all?
Yes, it is.
Thank you. So, heat-related illnesses has a variety of presentation, and it is important to sensitize the residents, the technicians, as well as the nurses to be able to diagnose this treatable condition and not let it go beyond beyond the severity and escalate further distance. So we know that the this is the equator. If you can see, the equator runs through the Indian this thing. It is the cancer. The Tropic of Cancer runs through the India subcontinent, and in fact, it divides it into two: the temperate zone or the subtropical zone, in where the Delhi lies, and the south part which is the torrid zone. So this zone here, this zone is the torrid zone on both sides of the equator, or it is also known as the tropical zone, and the subtropical is this area over here. So here, the south, we see a lot of heat-related illnesses, especially along the coastal margins. The Telangana, yeah, Andhra Pradesh. So this is why it makes it very important to be able to, be able to treat this and first diagnose this and then be able to treat it. So here you can see this is the you know the this is the Tropic of Cancer going across the India map, and the lower part is in the torrid region, and this, as I told you, the Andhra Pradesh, the Tamil Nadu area, okay, and the coastal margin, coastal Hyderabad, Visakhapatnam, all this area are where the and the Sahara, the Gujarat, the western area, they are, this is the annual temperature map of India, and it shows that most of the part of India, barring uh, the northern parts, is is in the category where the annual temperature is about 25, and the red part is where it is more than 27.5. So there has been a rising number of the deaths due to um, heat wave, and since last the 92 onwards, you can see on this, since 92 onwards, we 612 to what we observed in 2015, it was 2400. So it was very high mortality that we saw in year 2050, especially because there was a surge in the number of deaths, and the heat wave was intense. So it has steadily, you can see that it has been rising from 600, then to thousands, and then now it is up to 2000 and beyond. So in 2022 also there were heat wave episodes, and it was counted that about 203 heat wave episodes, the number of days uh, that was in terms of. So it has been rising year-wise. You can see the total number of average heat wave days has been rising, and the Uttarakhand, the Rajasthan, undoubtedly Rajasthan, Haryana, Punjab, these are having maximum number of heat wave days in year 2022. And as I told you, in 2015, the number of deaths was more than 2,000. And in 1995, there was another peak of deaths. This is the heat wave related deaths. It was also around 2,000. So it has been, this graph basically shows you that it has been steadily rising with few peaks every now and then. So as there is a increase in the heat wave days, the orange part, this is the peaks of the heat wave days, and the gray part is the mortality. So as there are increased number of heat wave days, there is more and more mortality. As you can see in 2015, in 2000 there's a high peak, and around 2005 also there is a very high peak. So it correlates that the number of the more the number of heat wave days, the more the mortality is there. So in 2015, what happened? It was mainly again, I told you that this part, as we saw in the heat, the heat map of India, you can see that this part, the coastal areas of Andhra Pradesh, Telangana, with the maximum number of deaths occurred, about more than 2,000, 2,300 people died during the year 2015. So, what is called urban heat island? What is it? Urban heat island. It is. It was a study done by the IIT Delhi in year 2012. They looked at many places across Delhi. There were 30 stations. They made some small stations, and they looked at the temperature of various places across Delhi, and they studied the satellite data as well, and they found that the very high temperatures were in those parts where there is a more of concretization, and there it was less in places like Buddha Jayanti Park, Hoskas District Park, as of course Sanjay one. So the more the plantation, it was the more the cool areas, and the high, very high, was in those areas where it was more of grit, especially like this Connaught Place area was very high, Noida area, and also Badarpur and Sitaram Bazar. These areas were very high, and also Bikaji and Kama Place. So this area has a maximum urban heat island ranging from more than about 9.1 to 10.7 degrees centigrade, and an average of about more than 4 or 4.3. So this is what has been happening, more and more concretization leading to urbanization and more of heat island formation, and that has been across the world, and like New York, Paris, London, Beijing, which are also dealing with the same problem as Delhi. So we need to actually create those islands where we have more trees and not more those concretization. So in 2014, there were 5 days of heat wave in Delhi, and in these 5 days only in these 5 days, 130 people had died on the streets. So this was a interesting thing that rather unfortunate thing that in 5 days only 130 people. These are usually those homeless people and those who have poor homeless people. So that is what is happening. Um, you know, in number of deaths that was reported in 2014. So this is again the Safdarjung hospital, where we have this Palam area where we have in year 2018 it was also clocked at 47.9. So it is coming to that time when we have persistently more than 45, but sometimes it clocks even 48 and 49 as well. So what is heat-related illness? Basically, it is a spectrum of disease, right from heat rash, uh, which is the just like your prickly heat, to just simple cramps in the so this is increasing in your severity. So more would be heat cramps where you have cramping in the muscles, to heat edema, just feet swelling in the after returning from heat uh, heat in the afternoon or in the evening. You see that there is a slight edema or more edema in the feet, or to some syncope. Syncope is just like uh, like a vasovagal syncope. Same thing. There's a heat syncope where the patient just collapses and suddenly he regains consciousness. To heat exhaustion, and finally to the heat stroke. So we will be looking at all these things in great detail, and especially the heat stroke and heat exhaustion, which are the dangerous uh, this thing. So what is a heat wave? Is when the temperature is about 45 degree centigrade or more, and severe heat wave would be when it is 47 or more, and at least two stations. This has to be there at two stations, and at least for 2 consecutive days. Uh, that we declare it on the second day, we declare that it is a heat wave or a severe heat wave. So 45 degrees. Or so, what is the thermoregulation? So there is a physiology of heat loss and heat production, and it is in balance, and it is totally what you call homeostasis, where the normal body temperature, the normal core body temperature is tightly regulated within about 1 or 2 degrees centigrade, and this is because of the heat gain and the heat loss, and this homeostasis is maintained by the blood vessels, the sweat glands, and the hypothalamus. So whenever there is an imbalance, either low temperature or high temperature, this the homeostasis is disturbed, and the counter measures are activated. So whenever there is a high temperature, what happens? This, whether the patient is exercising in a hot climate, climatic condition, what happens? The blood becomes warm, and it goes to the hypothalamus. The warmer blood goes to the hypothalamus and the preoptic anterior part of hypothalamus, and that activates the center. The preoptic nucleus gets activated in the hypothalamus, the anterior hypothalamus, and this sends signals to the blood vessels, to the sweat glands to activate, and the blood vessels will dilate. The capillaries become flushed, and this leads to the skin surface receives more and more blood, and that leads to radiation and the loss of heat from the skin. Whereas the sweat glands also gets activated, they start to secrete more and more sweat, and this perspiration is evaporated, and the body heat is lost via evaporation. So this is by radiation, this is by evaporation, and this helps in cooling the body to the normal level, and therefore once it is normalized, it shuts off. So it is homeostasis is maintained. Likewise, if there is a cold, although we are not decreasing, the same thing happens in the hypothalamus. The opposite things happen here. The blood vessels will constrict, and the skeletal muscle is stimulated to contract, and shivering occurs, which produces more heat, and the constriction of blood vessel will also conserve the heat, and this will increase the heat, and therefore the homeostasis is also maintained. So this is how the thing, it's a balance between heat gain by direct radiation or reflected radiation from the concrete, the heat gain, and heat loss is by evaporation, radiation, or the convection, the air passing and touching your body, or radiation from the skin, the skin keeps on radiating heat, or the air passing and touching your skin, and through convection, the heat is also passed off, or through direct contact by conduction. So these are the four mechanism: evaporation, radiation, convection, and conduction. And this is what we are also using in cooling the body when we are treating the patients. The evaporation, we are using fans, and we are using sprinklers, and for convection, we are using immersion. And so this is how we can. So there is a concept of wet bulb globe temperature. So most of the Western people, the Western countries, they are now measuring this wet bulb globe temperature, and we have also started looking into the humidity aspect. The air temperature, the dry temperature, plus the humidity, wind, and radiation. All these, radiation, wind, have to be taken into consideration. So we take the dry bulb temperature. This is called dB. So multiplied by 0.1 into the dry bulb temperature, whatever is there in our the thermometer, and then we have a sort of a water bath here and a thermometer, and the thermometer is slightly above the water bath, but a wet cloth is dipped into the water, and this, because of the wind, evaporation, and this measures the wet bulb temperature, and this is the natural wet bulb temperature. So this is how we are measuring. This is kept in the open to measure the natural wet bulb temperature. So we multiply that, we add 0.7 into this, plus 0.2 into globe thermometer. So this is the globe thermometer. So the solar radiation, it measures mainly the solar radiation, or the globe thermometer, and so we multiply that by 0.2. So all this will give us the wet bulb globe temperature, and this takes into consideration the air temperature, the humidity, and the radiant heat. So all these things are taken into consideration to measure the wet bulb globe temperature, because as the heat and humidity rises, as the humidity rises, the evaporation decreases and we feel more hot with the, as compared to the places where there is no humidity. So even with less temperature, dry bulb temperature, but with more humidity, we feel more heat, and there is high chances of heat strokes, because the evaporation is not taking place, which is the main mechanism of cooling of our body. So this is also known as what is heat index. Heat index is basically what we have just told you about the wet globe heat, the last slide, the wet globe temperature. So that the wet bulb globe temperature, we are actually taking that and measuring the heat index is how hot it feels when the humidity is factored, So when the humidity is factored, we calculate the heat index, and we see that even with the same temperature, and as we increase the humidity, even with lesser temperature, it feels more and more hot, with the lesser temperature than with the lower level of humidity. In fact, any humidity above 75, the evaporation decreases drastically, and chances of heat stroke is, it's quite high. So let's look at some of the risk factors for the heat stroke. Because this is the the severest form of heat-related illness, the heat stroke. We call it stroke because it presents just like any stroke, like a cerebrovascular accident. The patient is unconscious, not responding, and the temperature is very high. So what are the risk factors? There are internal risk factors, like the patient may be very young or very old, and there may be a history of alcohol consumption, or they may be having a pre-existing some diseases, whether it is respiratory, and they will be taking drugs also, which will dehydrate, especially with cardiovascular diseases, or respiratory diseases also. We give diuretics and other steroids sometimes in respiratory, which dehydrates the body, and some other drugs like, antipsychotic drugs, SSRI, and other amphetamines, and all those other medications and supplementations that we take, which are, which make us, uh, susceptible to heat stroke. Sleep deprivation, already dehydration, obesity, they're not acclimatized, they may be coming from colder environment, so they're not properly acclimatized. This is very important. Or it may be having some recent illness like a viral infection, or a sickle cell trait. Extrinsic external factors is if you're not wearing proper clothing, or you're not having protective equipments, you are doing exercise in the hot environment, you do not have water to drink, and the temperature is very high, the humidity is very high, and the wet bulb globe temperature is also very high. So all these are risk factors for this thing. So as we can see, from mild symptoms, discomfort like skin eruptions to heat fatigue, or heat, heat stress, or heat syncope, we keep on moving up to heat cramps, heat exhaustion, to heat stroke, and this all leads to it burdens the emergency room visits and physician, and lot of it really, and this also leads to finally death as the severity of health problems increases. So we need to catch them here, and we need to make them aware that we can intervene, prevent, so that the severe mode forms are not attained. So let's come to the symptoms of the heat-related illnesses. So mild category, we are talking about mild category. So it would be heat edema. So it would be like heat edema, just edema of the feet, or it can be heat cramps, which can be, usually these are, exercise induced, or it can be just heat rash. So it can be heat rash also. So we are talking about just rash, like we have the prickly heat, or it can be heat cramps, or just feet edema of the feet. So these are all mild forms of heat related illnesses. So what is happening in edema? Basically, there is skin vasodilatation because of heat, and this leads to, because of increased hydrostatic pressure, the capillary starts to leak, and once the capillary leaks, it leads to increased interstitial fluid and leads to edema formation. And this, how will the patient present? Of course, with the swelling of the feet, usually in the evening, and sometimes facial flushing also. So nothing much to be done. We remove from the heat, we elevate the legs, and diuretics are usually not indicated. We do not give diuretics because just by removing from heat, reassurance that it is nothing serious, elevating the legs would be sufficient, unless it is very severe, where you need to give diuretics or any other medicines. Now, heat cramps, as I told you, mostly it occurs during the exercise. They usually in the athletes who are running, especially in the humidity environment. So what is happening here? There is hyperactivity. There is hyperactivity of the neuromuscular junction. The muscle is overused, and the neuromuscular junction, there is a hyperactivity, and what is there? There is a depletion of the electrolytes and fluid. So this is what is happening, and this leads to muscle spasms, and the skin is usually moist, cool, and the body temperature may be normal. The body temperature is not rising at this moment, and the skin is moist and cool and clammy, and there is muscle spasm. So what is the treatment? Again, we remove. First thing is always to remove the patient from direct sunlight and take him to the shady area, elevate the legs, and just like in edema, we stretch the legs. Okay, we can massage the leg, we can stretch the legs, the muscles can be stretched, massaged, and of course, because there is depletion of the electrolytes, we can give electrolyte repletion. This should take care of the heat cramps. The heat rash, also known as miliaria rubra. So miliaria rubra is nothing but fancy name for heat rash or prickly heat. Gamoria, what we know in Hindi. So it is nothing but papules and sometimes pustules also. And the distribution is very important. They are red, papules and pustules. Distribution will be important. It is usually in the upper extremity, the upper trunk, the back, and the groin, and the neck area. And why this occurs is basically the skin undergoes vasodilatation. The sweat glands are hypersecreting. The sweat and the ducts get obstructed. The ducts, they get obstructed. And how do they get obstructed? It is because of the skin, the macerated skin, macerated stratum corneum. The macerated stratum corneum, because of lots of evaporation and lots of sweating, the skin gets macerated, and they block the sweat ducts or pores. So they will block it, and this leads to formation of these eruptions, and some infection may be there. So what is to be done? Remove clothing. In males, you can remove it, or in females, you can use light clothing, or then of course you can do evaporating cooling here can be done, which will relieve. There's a these are usually very itching. They are very itchy, and when you itch, it feels very inflammatory, and there is what we call this. It feels very hot and itchy. So applying ice or evaporated cooling really provides relief. And we do not give emollients because already the pores are obstructed, and they are, once you give emollients, you are again covering the pores, and this will make it difficult. So you give antihistamines, of course, that will itching will be prevented, and you can apply chlorhexidine cream, lotion, or you can give this salicylic acids 1%. Again, this can be applied in cream or lotion. So this is now moving to moderate category of heat-related illnesses. So moderate category of heat-related illnesses are usually two types. One is syncope, and the other one is exhaustion. So syncope basically means when the blood flow to the brain is temporarily, decreased, and once the blood flow does not go to the brain, the patient loses consciousness, and it's a transient phenomena, and the patient just suddenly drops, and once he drops to the floor, because the blood flow is restored, because of gravity, once the patient is standing straight in a hot, humid environment, what happens? There is a pooling of blood. There's pooling of blood. What usually happens in vasovagal syncope, just like that, there's a pooling of blood into the legs if it's standing. But here, what happens in heat syncope? Usually it is exercise induced. It is exercise induced. What happens? Because of exercise, there's a lot of water is lost in sweat, and there is a vasodilatation. So there is a generalized, profound peripheral vasodilatation, right? So, and volume is depleted, okay, because of lots of sweating. Lots of sweating is there, and what is happening? The moment you stop exercise, as long as you're running, the muscle pump is, it is pumping the blood. But the moment you stop running, all that, vasodilatation, the blood suddenly pools into these vasodilated vessels, and you get what is called is, you get syncope. So it is, what is the symptoms? Lightheadedness, orthostasis, dizziness, and transient loss of consciousness immediately after cessation of activity. Immediately after. So this is the characteristic. So if you can take the history, this will be forthcoming, and this is the reason why it is happening. So what you do, you again make him lie down in a supine position. Of course, there's dehydration, so you give IV or oral hydration, and just by this should be able to, because should should be able to. If the patient is not recovering, of course, you should think about other things, but this should be enough. Then comes to the more severe form, that is the heat exhaustion. So what is heat exhaustion? Is basically because here the core temperature will start to rise. Okay, the core temperature, as I told you, it starts to rise to 101 degree to 104 degree Fahrenheit, and this leads to thermoregulatory dysfunction. So hypothalamus is no longer able to, control the balance or maintain the homeostasis. And there is dehydration, there is hypovolemia, and there is a hypotension, and there will be some multi-organ dysfunction early, not profound, but some early multi-organ dysfunction, right? So this leads to what is called heat exhaustion, where the patient feels thirsty, there will be headache, there may be severe fatigue, and heart rate will be high, severe weakness, severe fatigue. They will not be able to walk properly. They will be ataxic. Syncope they may throw syncope, or they may develop syncope. They may have nausea, vomiting, diarrhea, and the skin is cold and clammy because they are still sweating. In heat exhaustion, they are still sweating. So these are the symptoms. Patient will have thirst, fatigue, severe weakness, tachycardia, headache, thirst, and some CNS manifestations like ataxia and syncope, and all these things will start to come. Again, move the patient from the heat, rest in supine position, elevate the legs. So far, we have been doing all these things. But here again we start evaporative cooling because the temperature is rising. Till now, the temperature was not rising, but now the temperature has started to rise. So we need to do cooling. So cooling is done here, evaporative cooling. And what is that? Evaporative cooling means we remove the clothes, or sometimes in the in the periphery or in the fields, we don't have this much time. Also, sometimes we need to act fast, especially in heat stroke, where we need to do immersion, do immediate immersive cooling. We do not have time for removing clothes also. So we can do, if in this heat exhaustion, we remove the clothes, we sprinkle the skin with water, and this will be tepid water, about 15 degrees centigrade. It should be cold, and either you use ice cold water or you can use tepid water. Tepid water means up to 15 degrees centigrade, and that we sprinkle it and we use the fan for the evaporation. So this is very important. So this is called evaporative cooling. And we give hydration, which is very important to replenish the electrolytes, because sweat contains a lot of sodium and other things. So it uses a lot of sodium and potassium. We need to replenish, rehydrate by IV, or if the patient is conscious, we can also give, along with it, we can give oral as well. So this is important too. And we do all the investigations to see if there is a multi-organ dysfunction developing in these patients. Now coming to the severe form of this thing, heat-related illness, and that is the heat stroke. And of course, I told you why we call it stroke, because it is the severest most form, and the presentation is just like any, and the mortality is so high that it is akin to like your, the cerebrovascular strokes. So the mortality, as I told you, and we need to act very fast. Every minute counts, every second counts in these, and proper treatment is essential. As I told you that sometimes we don't even wait for the removal of clothes, we just immerse the person. So what the person is coming here is with altered mental state. So till now, the CNS manifestations were not there, but in these cases, it is profound. The CNS manifestation in these patients is profound. The CNS manifestation is profound in these patients, as with altered sensorium and coma also. Patients can come in coma, and the temperature in these patients is very high. It is 105 degree. Right. So how do you measure this core body temperature? We usually use the rectal thermometer. We insert, it is about 20 centimeter rectal thermometer. We insert about 10 centimeter inside to measure the, or we can use the esophageal thermometer, which is also is equally good. But oral temperature or the skin temperature is not good. It is not depicting, it's not correlating with the core body temperature. So it is essential to use the rectal temperature, or we can use the esophageal thermometer or the rectal thermometer. So here, what is happening is severe thermoregulatory dysfunction is happening. So now the hypothalamus is totally knocked out. It is not able to function. So if it is not able to function properly, then there will not be any sweating. As I told you, because of the autonomic nervous system activation, there is sweating, and so here the sweating will stop, and this leads to damage to the cells, and the damage to the cells leads to the endotoxic leakage, and that leads to systemic inflammatory response syndrome, uh, and also leads to cellular deaths. So most of the multi-organ dysfunction, so cellular apoptosis or cell death occurs because the cells are not able to cope up with such a high degree of temperature, and because of inflammatory response and the endotoxic leakage, all these things leading on to severe multi-organ dysfunction, which we will multi-organ dysfunction, like brain dysfunction, heart dysfunction, and the kidney dysfunction, and the liver dysfunction. So all these organs leading to DIC also, some we'll be looking at that later on. So basically, it presents just like multi-organ dysfunction. So any fever with altered sensorium state, seizures, coma, with tachycardia, tachypnea, and hypotension. So we usually think it is an infectious cause because it presents just like your any infectious like viral encephalitis, or even uh, this any encephalitis, whether it is meningoencephalitis or even typhoid, this thing, or sometimes endocrine, like thyrotoxicosis can also present with all these manifestations. So there's a huge list of differential which we will look at. So these just going through this, so they will be having some amount of diaphoresis will still be there. It is not that it will immediately stop, but you can have a dry, totally dry skin at the time of presentation. So what is the treatment? Treatment is immediately remove the patient from the heat. Of course, we look at the airway, the breathing and circulation. Circulation means the patient is already in hypotension. We need to give fluids, lots of fluids, and if that doesn't work, we can give colloids also. Breathing, we have to see whether the breathing is proper or not. If not, then we need to intubate. Airway, we see if there are any, the airway is patent, and all these things. And immediately we go for water immersion therapy, cold water. It is ice water immersion therapy, where we, below the neck, we immerse the patient into a, tub, or a tub-like, arrangement, where we can, immerse the patient below the neck with cold ice water. The temperature of the ice, the water should be around 1 to 3, or even up to 1 to 5 degrees, some people say. But that is very important to maintain it at 1 to 3 by adding more and more ice into it, and more this thing. By simultaneously, we measure the temperature of the water as well as the temperature of the person. And as the temperature from 105 degrees or 106 degrees starts to come around 102, we take the patient we take the patient out of the immersion, cold ice water immersion. We take him out at around 102. The reason for that is we don't want the temperature to go beyond or less than 102, because the vasoconstriction will occur and they will be shivering, and that we do not want, because shivering will produce more heat, and that is what we don't want. So at 102, we that is what is the reason for uh, keeping a thermometer in the tub as well, in the water, so we can measure the temperature of the this thing also, so that we can keep the ice cold water at 1 to 3 degrees this thing uh, as centigrade, and the rectal temperature, so that we can measure the core body temperature. As it goes to 102, we can remove the person, and of course we will hydrate the patient, and we have to, of course, admit the patient, send all the investigations, especially coagulation profiles, because the patients are likely to develop DIC, disseminated intravascular coagulation. So this is quite one thing where we will send all the coagulation profile, the platelet count, the TLC, DLC, and of course the liver function test, the kidney function test, because there is liver failure also. The hepatocytes, these cells of the liver cells, they go apoptosis. Similarly, the apoptosis of the renal cells, and also rhabdomyolysis. The muscle cells undergo apoptosis, and that leads to this thing. Lots and lot of myoglobin release from the muscles, and these myoglobulins as well as other proteins will go and clog the cause renal failure. And see, this is what is important. Rhabdomyolysis will also cause hyperkalemia. Potassium will also go high, because lots of potassium will be released from the muscle cells, and this will be another problem. So electrolytes will send liver function test. We will also look at chest X-ray, the ECG also, because the lungs and the heart will also undergo heat injury. The lungs may develop ARDS, or may develop hemorrhages or edema or other type 1 respiratory failure or type 2 respiratory failure. The heart dysfunction may occur, the coronaries may clot, so there may be myocarditis or a stunned sort of a myocardium, where you can develop hypotension, and the muscle enzymes of the heart, heart muscle enzymes may be elevated. And all this, and of course, the central nervous system is the main thing which is getting disturbed here, with CNS coma, seizures, altered sensorium, and whatnot. So all the symptoms of CNS dysfunction, heart dysfunction, all the symptoms of liver dysfunction, everything can develop. So it is as you can see, it is a multi-organ dysfunction, and it is causing a severe sort of a severe sort of a clinical picture. So if the patient develops DIC, we have to be, we have to see whether the patient is having, more of a bleeding, or is it more of a thromboembolism type of DIC. So that needs to be managed. If there is more bleeding, of course, if the platelet is less, it is just symptomatic management. If the platelet is less than 20,000, we need to give platelet concentrate. And if the patient is bleeding, or the fibrinogen is less, so we need to order fibrinogen level as well as PT, APTT. Each test needs to be sent, and we need to treat them accordingly. If the PT, APTT is more than 1.5%, and the patient is bleeding, then we need to replace it with factor concentrates or fresh frozen plasma. again, if the patient is already bleeding and the platelet count is, even if it's less than 50,000, we need to give platelet concentrate. Of course, we can give other things. So if there is microthrombi, then we need to take the help of, low molecular weight heparin, or even unfractionated heparin if there is no, we do not have low molecular weight heparin. If there is arterial events, then we can also add antiplatelet treatment. So this is basically symptomatic treatment. So now coming to the, some of the pictures, which of course I've taken from the internet, and these are the basic prickly heat or the heat rash. So these are macular papular rashes, and they're itching, they're pruritic, and they're red. So this is very, very common presentation, and this is a common presentation of an athlete, after finishing, or even during the running, uh, you get a heat syncope. Usually it occurs after, after completion of the, uh, as I told you, because of the uh, peripheral pooling, and there is a less blood for the brain because of generalized peripheral vasodilatation. And sometimes what you come across a patient because there is a hyperventilation, and the because of heat causes hyperventilation also, and you get this kind of tetany, and sometimes chopstick sign may also be. This is Strauss sign, and chopstick sign also you get when there is, you in front of the tragus you press, and there is, angle of the mouth deviates from the skin. So there is twitching of the, and this basically again sport muscle cramps. It's very severe, painful cramp occurs during exercise. Because of the neuromuscular hyper excitability, the muscles get, and so you need to elevate the leg, and you need to stretch the muscles and give him electrolytes. So, of course, I told you there is a lot of differential diagnosis which we need to come, and then only we can say that it is a heat stroke. Of course, you need to rule out infection. So you need to send, sepsis profile, blood cultures, urine culture, and other cultures if there are, and rule out meningitis by doing cerebrospinal fluid analysis. So because the presentation is always similar, and there is a fever, there is altered sensorium, there may be seizures. So encephalitis is a very big, differential that we keep, and all these things will require CSF examination, and brain abscess. You need to go for, CT examination before doing CSF. You need to, look at the brain by doing the non-CT contrast. This thing. If there is, there's a history of wound infliction is there, and there is opisthotonus, then maybe we can think of tetanus. Otherwise, malaria and typhoid we must rule out because they are very common in our subcontinent. And there are multiple drugs and toxins which we need to rule out, like, because all these drugs, they alter the, they cause this hypothalamic dysfunction. So, the hypothalamic dysfunction is, is the central core of heat stroke, because ultimately what is happening, the hypothalamus is knocked off. So the heat, losing mechanism is lost. So most of the drugs also, act that way, or at least they, they contribute to heat stroke. So all these drugs, especially the, these neuroleptic drugs, or malignant hyperthermia, even some psychoactive drugs, you need to like, amphetamine, cocaine, anticholinergic drugs, uh, especially the, the SSRI, some patient may be on diuretics, dehydrate, and alcohol, so stimulant drugs, all this, you need to look at. And neurological conditions, of course, if it is a heat stroke, it can be a normal stroke also. So you need to look at that. But here, because there is a high fever, it can be a hypothalamic stroke because the hypothalamus is knocked off and there is a high temperature is there. And of course, if the patient is having seizures, we may be looking at status epilepticus. We can be looking at hemorrhagic, like pontine hemorrhage. The patients, have, some, they have this, pinpoint pupils, they have hyperpyrexia. That can be a differential diagnosis. And of course, in the endocrine part, I would like to point out this thyroid storm, which presents just like that. Fever, there will be high grade fever, altered sensorium, maybe in patient in coma, and it may be just a thyroid storm. Tachypnea will be there, tachycardia, respiratory failure, and pheochromocytoma. We saw a patient of thyroid storm with same presentation. So all these things, and of course, don't forget the leukemia, lymphoma, and all these things we can also present in same. Now, this is just looking at some of the posters which has been going around, and you'll be seeing this in your hospitals. And if you have not seen them, please do put them. These are for the education of the the general public, and what to do, what not to do, and how to recognize, to sensitize them, about the heat stroke and the manifestation of heat-related illness, and what to do. Visit the doctor or call the ambulance, and if you're not, so these things, and who are the at-risk population? I told you the pregnant female, the elderly, or the young children. They are the ones which are at risk. And so go through this. Whenever you see these posters, please, these all things have already been covered with me. But do tell your colleagues, and be be in the lookout for these. Only when you suspect these things, then only you will. And at the workplace also, some of the workers are at very high risk. Especially those who have, like the policemen, the traffic policemen, and those street vendors. They are all working in the heat, and the laborers. So all these are special task force which have to work in the high. So we ask them not to work during the high heat time. That is, the high heat is around about 12 to 4 o'clock, or 12 to 2 at the most. We ask them to take rest, and then so all these symptoms, they have to be told as well. So first aid measures is to keep ORS, and drink water. Not only water, but you need to give salts as well, and you have to wear proper clothing. It's very important. Not to wear dark and synthetic clothes where the evaporation is not taking place. You need to wear cotton clothes, and immediately you move to a place where and you can do evaporative cooling if required. So in the work environment also, you need to provide a lot of cool drinking water facility, and a timely medical care, and frequent breaks in the so that is what 12 to 2 may be regarded in the severe heat part of that. And you need to provide cool and comfortable area for their children as well. And you have to look at their those people who are at risk, those who are taking some diuretics, some medications, and maybe you can give them some assign them some different work or something like that. So do's and don'ts, as I told you, do not exercise. Alcohol is a totally no. Tea, coffee, sugary drinks, a totally no. Don't exercise, especially in the sun. Avoid going out of 12 o'clock to 4 o'clock. Do not leave the kids, and cooking also produces a lot of heat and a lot of sweating occurs. So these are certain things which you need to be this thing. So coming to the take-home message, remember, prevention is better. We don't want to treat heat stroke We don't, but they do happen. So we have to keep that in mind. Immersion cooling is always better than evaporative cooling. Remember that in heat stroke. And every second counts. Remember this. This is very important. We need to do it so meticulously and so because every second it means cell loss of cells. We don't. So it is a cytotoxic event. Heat stroke. It leads to the cells. They are not able to maintain the homeostasis. So antipyretics do not have any role. Remember that because it's not the it's there is no pyrogens here. So antipyretics don't have a role here. So IV paracetamol or any such things will not have any role. Only evaporative or immersion cooling is the and of course I told you rectal thermometers or esophageal thermometers better than oral thermometers or skin thermometers because we need to measure the core temperature rather than and be on the lookout for the multi-organ dysfunction, especially DIC, rhabdomyolysis, and ARDS, the AKI, and all these the liver dysfunction. All these things you have to be look out for. Uh, so this is all. Thank you for patient listening. Thank you.
Thank you, sir. Yeah, coming to the next presentation, Dr. Shaw. Over to you, Dr. Shaw. Sir,
Dr. Sanjay Kumar, has he finished his talk? Can I request Dr. Shaw? Yes, sir. Please.
yeah, sir.
Thank you, sir. Thank you very much for this opportunity. I'll be basically covering the pediatric aspect, and Dr. Sanjay, my previous speaker, has already made my job very simpler in a way that most of the things are already discussed, and I'll be dealing mostly with the pediatric part, and that too mostly with the preventive part. So basically under these three headings is like what should be the preparedness like in schools where most of the children will be if they're not at their homes. What kind of awareness is required for parents and children? I will come with some simple advices which are doable in school and at home. And of course, management of heat-related illnesses in children where fluid and the rates, they will differ for the serious heat-related illnesses in case they are getting admitted. So to start with the schools where majority of children will be there, unless the schools are closed those days, and the administrators might decide that the school holidays will be on these dates, and they should actually be in a lookout for, in case it should be preponed and postponed also. So what was planned a year back or a few months back may not be necessary today. I mean, maybe the heat is far more than that or lesser than that. So it can always be preponed or postponed, the holidays, summer holidays. In case the school is open, then the first and foremost is availability and accessibility to potable water. Now, again and again, this fact is coming that the important thing is that we stay away from heat and we hydrate ourselves well. That's it. So whichever way we can do that. So very important that we have availability and accessibility to potable water. And what I mean is by that is that not only the presence of water cooler, it has to be clean, ensuring regular cleaning and monitoring. I know that many students, they don't take from water cooler just because it's not clean enough or they feel it is not clean enough. So the school authority must look into this, that it should be actually potable, drinkable. Then the classrooms, they should be well ventilated, and the school authorities must ensure cross ventilation of the rooms. There should be enough ceiling fans or AC. Still, there is few days time maybe in case the heat is still like not much. The first thing to be done is that see that ceiling fans, AC are all working. Backup electricity is a must during class hours, so that if there's no electricity, at least the fans will be on or AC will be on. And one cool room inside is cool. And what do we mean by cool room is that basically an AC room where 1.5 ton AC is there for 15 by 15 feet room. So that's a simple calculation. So these all should be there in every school. What other measures at school? Okay, so first thing is that the students should be told that to avoid plastic water bottles. And the school timing should be such that it must start early and close before peak temperature. Peak temperature, what do we mean is that 12 to 3, 12 noon to 3 p.m. time. So that is the like most hot time. So preferably before that, if the school can be closed, or just around that time. There should be flexibility of games and sports period based on temperature and humidity factor. It might vary depending on which part of the country we are in, and we have to take that kind of steps that when there is high humidity or high temperature or both, we must avoid outdoor games and sports. Generally speaking, no major outdoor sports events should be held during the summer months, and in case of excess heat, even recreational activities should be indoors only. So that's very important under the shed. The clothing of the children, they should be comfortable. They should be loose, lightweight, light colored, and avoid neckties. They may be so that the neckties are part of the uniform, but this is a time where neckties should be kind of excused. It should be very light clothes. And of course, strict adherence to summer holidays. If there are summer holidays, if it is already like known that it's peak of summer, let the schools be closed. And also there should be flexibility in administrators' hands to prepone or postpone if the need be. Now, other than what the school authorities will do or what the administration will do, there are many things the students and the parents also should be aware of. And this is very, very important. Now, encourage more drinking of water by teaching the beneficial effects of drinking water, and also water with added minerals, okay, like some amount of salt in water, sometimes ORS, nimbu pani, those kind of things. As heavy sweating removes salt and water both from the body, and that need to be replaced. Here, one very important advice that should be told to the children and parents, that the children have got this habit of playing outside and also not to drink water till they are feeling thirsty. So there should be some, I mean, kind of discipline or advice or whatever you can say, that this children be told that you please take water even if you are not feeling hungry. That's very important. And also to curb this, playing under the sun. So these two are, they are naturally inclined to do these two mistakes, and that the parents should tell them not to do. Then remember that to avoid fruit juices, sugary drinks, or carbonated drinks, they don't do any good. They should be avoided as a substitute for water. When we say water, it is water, or maybe shikanji or traditional Indian lemonade, nimbu pani, aam panna, bel sharbat. They will do, but not fruit juices, sugary drinks, or carbonated drinks. Then this is also the time when children will have a lot of prickly heat. Okay, so they should be taught the importance of bathing each day to prevent skin infections and also prickly heat. And what needs to be done for prevention and treatment of prickly heat, I'll just come little later. If they're not in school, or children are being parked, they're sitting inside a parked car. So important is that the windows are open, firstly, and secondly, don't leave the children in a parked car even if the windows are open. Okay, so look before you lock. That is the kind of tagline. Then wear sunscreen, broad spectrum sunscreens, which give ultraviolet A and B protection. And also, if not, then at least use umbrella or hat once outside shades. A little bit of heat also at the peak of summers can be dangerous. So as much as possible, stay away from direct sunlight and heat. And also the awareness about early signs of dehydration. These the parents should know, the school teachers should know. So before the medical personnel come into play, the society at large should be well aware about the early signs of dehydration. What are they? If the children feel faint, or they say of extreme tiredness, was otherwise playful, but today this child is not playful. The child is talking about intense thirst or having fever, headache, or the child is nauseated, vomiting, not passed urine for hours, or is passing concentrated urine, or both, or the child is breathing faster or deeper than normal. So they are signs of metabolic acidosis or high temperature. In both, the breathing will become faster and deeper. Skin numbness, muscle cramps, dry tongue, and sunken eyes. Dry tongue and sunken eyes is more talked in children because these are very important ways of knowing dehydration, which we also teach in diarrhea dehydration. So the mucous membrane also gets dried, and sunken eyes, which is, easily it can be elicited. Now I come to some innovative ways of knowing whether the child is about to be dehydrated. So this slide has been made from the internet, and I came across this from the Australian government website, and which I found to be very nice way of and doable in schools and other places. So what it means is that these kind of posters can be made and they can be put in the washrooms of the school where the children are going to pass urine. So when they are passing urine or in a prominent place, this poster is there and it's written, am I drinking enough water? Use this urine color chart to assess how hydrated you are, and it is important to drink plenty of water every day to stay healthy. So 1 to 2, if you see, it's quite colorless or very light yellow. So pale, colorless, odorless, plentiful urine. This is an indication that the child is well hydrated. So the message for the child is keep drinking at the same rate, which were he or she is drinking. Next comes to 3 or 4, where it is slightly darker yellow urine and it indicates that you need to drink more water. So the message is drink a glass of water now. So as soon as passes urine, please go back and drink a glass of water now itself because you are getting mildly dehydrated. It means that. Then is the color code 5 and 6, where it is now medium dark yellow urine, and it's an indication that the student is dehydrated. So now must drink 2 to 3 glasses of water. Now the problem starts. 7 or 8 is an emergency now. Now it is darker, strong smelling urine and very small amount. It's a sign of dehydration. And now drink a large bottle of water immediately and also inform, the teacher, and probably at dehydrated stage and very dehydrated stage, it must be informed to the school authorities or teachers. So also important to remember is that what can change the color of urine otherwise also, in case the child is taking some kind of certain food, medications or vitamin supplements, then can also urine color can change. And of course, this is not a it's not an alternative to the advice of health personnel. So in case the child is having other symptoms and signs, and even if this urine color test is not done, still the child must come to attention of a health professional. But this is a very simple way of knowing by the student itself that he is or she is dehydrated. Now I come to the heat-related illnesses that we see in pediatric age group, and the commonest, as I said, is heat rash, also called milia rubra, also called prickly heat. So what's the treatment? Treatment is always placing in a cooler environment under a shade. Come back from that place where it was under the sun or was outdoor. Please come inside. Remove excess clothing and avoid application of lotions. It does no good. So what is helpful? If you want to prevent this, then use loose-fitting clothes and remove excess clothes. Avoid direct sunlight. Avoid excessive heat by any means, and frequent breastfeeding of fluids. It's written breastfeeding here because even infants are also prone for this prickly heat, and in newborns or in small infants, what we give advice is that please feed more and more because they are also susceptible. They also come in pediatric age group. And in case it's a bigger baby, then more fluids. Next is the child may have just excessive irritability and dehydration, and again the treatment is the same, that you place in cool environment, remove excess clothing, and frequent breastfeeding or fluids. Next is heat edema, which it basically means swelling of feet, ankle, and hands, but it is more common in adults though, but maybe adolescents or bigger children can have. And the treatment is again remove from hot environment and place in a cool environment, which is common for all heat-related illnesses. And here you must elevate the affected extremity. Generally, it's self-limiting or short-lasting kind of. Next is heat cramps. This will be more common in young athletes or somebody who was otherwise not very, doesn't do much of movement or doesn't play much, but that day has played a lot. Or, in a company where he or she didn't realize that he's generally doesn't do this much of activity and does. And then what happens is that there's painful, involuntary, spontaneous contraction of muscle group of legs, calf, or groin. So what do? You remove from hot environment again. Rehydration is very important. Frequent oral fluids. If versus the intravenous fluid, and also somewhat of massage or stretching exercise should also be done. And also, here's a situation where somewhat of salt in water will also help a lot, because electrolyte imbalance can also happen. Next is heat syncope, and it is seen with prolonged standing in hot environments, like in the morning, under the sun, if the children are standing for a long time, and that causes vasodilatation, and so a fall in blood pressure due to venous pooling in the legs, and that causes decrease in venous return to the heart, and so fall in cardiac output, and so lesser blood supply to the brain, resulting in fainting or feeling of lightheadedness. What do? You again remove the child from a hot environment. That's common for all conditions. And you do oral rehydration with salt-containing fluids. And you have all these options like ORS, lassi, nimbu pani, lime water with salt and sugar, rice water, dal water, coconut water, sattu, anything. Whatever is culturally admissible. Just that no fruit juices, no carbonated drinks. Next is heat tetany. And the difference between this is that it can be differentiated from heat cramps or the fact that there is very little pain or cramps in the muscle. But heat tetany is because of basically decrease in ionic calcium. And why it happens? Because the child is hyperventilating because of excessive heat. So you remove the child from a hot environment, you calm the child to decrease hyperventilation, and if still not relieved, then maybe child has to be admitted and to be given intravenous calcium. Next condition is heat exhaustion. And what happens is that after prolonged heat exposure, the body temperature rises up to 104 degrees Fahrenheit. And it leads to dehydration, tachycardia, vomiting, fatigue, headache, but normal mental status. This is very important. Mild confusion can be there, but normal mental status. Till this point, when the temperature is not up to 105 and there is normal mental status, it's still in heat exhaustion range. Okay, it's still maybe manageable at the school itself. So treatment is remove the child from hot environment, oral dehydration with salt-containing fluid. In case the child has been admitted or there's a feasibility is there to get to the hospital, then look for dyselectrolytemia, do intensive care monitoring, IV rehydration, and rule out sepsis. The next condition is the most dreaded one, that is heat stroke. This is the serious most condition among the heat related illnesses. What happens now? Now there is prolonged exposure to heat, and this has led to core body temperature rising to more than 104 degrees. So 105 and beyond Fahrenheit or 40 degrees centigrade. This is the difference from the previous condition, that is heat exhaustion. In heat stroke, what is happening? Now the patient or child is presenting with the neurological symptoms like stupor, coma, drowsiness, confusion, delirium, hallucination, seizures, ataxia, and anhydrosis. In heat exhaustion, there was excessive sweating, it like over hands and feet. But now there's anhydrosis. This child is very prone for coagulopathy, as was told in the previous presentation also, and prone for multi-organ dysfunction. This must be taken very, very seriously. These cases must be admitted. These cases must be transferred in an AC ambulance. But the treatment must start from the spot itself. This is very important. Please take the child inside to an AC room or under the fan. Just sprinkle water over the body and put a fan over there. Try to reduce the temperature as much as you can till the ambulance is coming. Okay. So this is very important. Do not delay. And whichever way you can cool down the child, please go. Once admitted, this child, I will come to the entire protocol a little later. Now, once admitted, must check airway, breathing, circulation, the way I do ABC, because this is a very, very serious condition. Give oxygen, IV fluid connection, and the child will be dehydrated now. So you have to give 20 ml per kg of fluid. And what we give is NS or RL. And then NS, you repeat 20 ml per kg up to 3 times, 60 ml per kg maximum. And then you have to continue maintenance fluid. So at the same goal, let me talk about the maintenance fluid also in children for those who do not manage children, is that up to 10 kgs weight, we give 4 ml per kg per hour of fluid. Okay. So up to 10 kgs, 4 ml per kg per hour. 10 to 20 kg children. So first 10 kilo, 40 ml per hour, 4 ml per kg per hour, and then 10 kilo plus, whichever, like let's say 15 kilo weight. So 40 for first 10, and next 5, you add 2 ml per kg per hour. So 2 into 5 is 10. So for a 15 kilo child, you will be giving 50 ml per hour of fluid. That's the routinely replacement, need of a child. And then if the child is more than 20 kg, then for every 1 kilo, 1 ml per kg per hour is added. So what do I mean by that? Let's say a child is 25 kgs. So first 10 kgs, 40 ml per hour, 4 ml per kg per hour. 10 to 20 kgs, 2 ml per kg per hour, so 20. So 40 plus 20, 60. And for next 5 kgs, it is 5 ml per hour. So the instruction will be 65 ml per hour of fluid. And what fluid we generally give for maintenance? We give DNS. Okay. Now, here is a case where you must do random blood sugar, arterial blood gas to look for metabolic acidosis, electrolyte imbalance can be there, sodium, potassium, calcium, both should, all should be done. Liver function test, renal function test, very important. The child may go into renal failure. Coagulation profile also should be done. And in case the child is having an altered sensorium and it is a long-lasting one, and you have a suspicion of CNS bleed or CNS infection, then neuroimaging is also a must in this case. What are the danger signs that everybody should know? These are refusal to feed, excessive irritability, decreased urine output, and dry oral mucosa, and absence of tear or sunken eyes, lethargy, altered sensorium, seizures, and bleeding from any side. If any of these are there, these are all a danger sign. The child must be admitted and must go for intensive care monitoring. Now, for the management of heat stroke, a typical management, I would like to take you to another document. So I am, because I couldn't incorporate it in this. So I'll just a moment. I'll stop sharing this and I'll share another document again taken from the documents that is available in the website of Ministry. So I think all can see this. Can someone please confirm that this document is seen now?
Yeah.
Okay. So in a nutshell, now what do you do in case you are dealing with a case of heat stroke or severe heat exhaustion? So this should be there, should be pasted, a poster should be there in each hospital maybe. And this is how you proceed. You assess the airway breathing circulation and you document the neurological impairment. You ensure IV access immediately, send relevant investigations. I've already told you about the investigations that needs to be sent. Consider intubation if necessary, because if the child is, comatose and cannot maintain its airway, prone for aspiration, you consider intubation. You consider benzodiazepines. Benzodiazepines, what we mean is midazolam and lorazepam. Midazolam and lorazepam for seizures as well as for excessive shivering. So remember shivering, because the child is now being cooled, is sprinkling water being done, evaporative method, say, you are cooling down the child, may start shivering. So shivering, the treatment is also the same, midazolam or lorazepam. And if you want to just remember one figure, then it is 0.1 mg per kg per dose, give over 5 minutes. So you are safe. If the child will invariably be in shock, and so you give normal saline bolus 20 ml per kg and reassess, and you can repeat boluses up to a total of 60 ml per kg. So one fluid you have to remember, normal saline 20 ml per kg. Give it fast in 10-20 minutes, and then you give up to 60 ml per kg. But watch for features of fluid overload. And once this fluid has been given, then you continue normal maintenance fluid that I've already explained. If there's no shock, then assess dehydration status, correct and start normal maintenance fluid. This part you need not give this boluses. Remember, boluses are not, out of, there are risks involved, because once the child gets cooled and that vasodilatation go off, then the extra fluid, whatever is there in the vessels, peripheral vessels, they all will come into the central vessels, and then, there may be increased chance of pulmonary edema. So be careful. Active cooling measures that should be done from the spot itself is removal of all clothing while protecting patient's dignity if possible. If not, at least cover with thin wet sheet or just spray cool water over the body, even with the clothes on. If ice pack is available, then put them over head, neck, groin, and axilla. Use mist fan, that is evaporative method, just normal fan, just put over the child and so that it evaporates the water that has been sprinkled on the child. Tepid sponging or cool blankets if available. Make the child lie down, raise the feet slightly. That will also help from this dehydration and shock kind of condition because that the pulling of blood that has happened in the feet that will come back to the heart. Remember, avoid paracetamol NSAIDs. There's no role of paracetamol or NSAIDs in heat stroke or these heat hyperpyrexia conditions. Consider gastric lavage with cold saline in case that can be done. Close monitoring, like temperature every 15 to 30 minutes, and do not overcorrect to less than 38. So what we mean is that please correct till 102 and then stop, because after that the cooling will continue. The cool blood from the periphery will also come to the center. There are chances that the child may go into hypothermia if you keep on cooling. So stop at 102 and then let the child recover slowly. Hypothermia also fatal and it is not good for children. Khas karke for the smaller children, young infants and all, hypothermia can be extremely dangerous. Vital signs like BP, heart rate, saturation should be seen. You watch for altered cardiac rhythm. So if ECG facility is there, do that. Altered mental status, you do GCS monitoring and look at the trend. Look out for complications of treatment, that is acute pulmonary edema. I told you that whatever treatment you're giving for shock, just be little careful. Look at the basal crackles, look at the liver size, and don't get into acute pulmonary edema. Hypothermia is also possible in case of a vigorous cooling. For seizures and for shivering, you can give benzodiazepines, as I said, midazolam 0.1 to 0.2 mg per kg per dose, and lorazepam 0.05 to 0.1 mg per kg per dose. So easy to remember, just remember 0.1 mg per kg per dose for both to be given over 5 minutes. Prevent shivering by paralyzing patient if intubated. If don't want to paralyze and if not intubated also, then no way you can give paralyzing agent. You should give either midazolam or lorazepam. That will also help in preventing shivering. Look for signs of coagulopathy. These heat stroke conditions are notorious for coagulopathy. And in fact, clinical bleeding also can be there from the orifices. And what to be done in that case has already been explained by the previous speaker. You must do ABG regularly to look for metabolic acidosis. CT brain may be done to look for complications or rule out intracranial pathology. It all will depend on the trend, like how quickly the child is improving and if is there any alternate setting or alternate diagnosis you are contemplating. Continue management and referral to intensive care unit. And last, which generally is not much discussed if it is not a child, that please inform and communicate with next of kin regarding patient condition and prognosis. The entire family suffers when a child suffers. So the parents and whosoever relatives are there must tell about the condition at arrival and also as the child improves or in case deteriorates or whatever, but make it a habit of communicating to the patient relatives. This is a must for children. So that is all from my side. I have finished. Over to the organizers, over to the moderator. Thank you so much.
Thank you, Dr. Shah.
So,
Yeah.
thank you, Dr. Shah. I think your presentation is now over.
Yes, sir, it's over. Sir.
Okay. So, thank you once again to Professor Sanjay Kumar and Colonel Dr. S.C. Shah for their taking out time to provide this important webinar to the clinicians that have participated from different states and districts of the country. And all the people who have joined, I would request you all to make an understanding of what has been provided in the material today. A lot of the content related to protocol is also available on the guidelines which have been circulated under the program. Please make use of these guidelines and protocols, put them in prominent places in the patient care places, especially if you have heat stroke beds and heat stroke rooms, and also take the necessary measures as I read out in the beginning of the webinar today about what has been of concern in the reviews taken up by the senior officials in relation to the preparedness to the heat season of 2024. And these materials will be available on the NPCCHH YouTube. The links will be available for you who have missed the opportunity to go through the recorded material, so that you can circulate it for those clinicians, pediatricians, and physicians who unfortunately could not attend the webinar, and also the medical officers from the various healthcare units. And we have also provided for an facility assessment checklist to assess your preparedness as per the directives that we have received in the program. And you are all are requested to fill that checklist. It's on a Google form, less than 5 minutes. The link has been provided in the chat for all of you. Please fill that checklist. Will help you to guide through what are the necessary points that you need to work on in your health facility and ambulance preparedness, and also for you to able to assess and update what is the status. There are provision of funds in the NPCCHH and NHMPIP to be used to ensure that the logistics are in place for this season. Please make use of them. With that, thank you all for joining with us, and hope we are able to together make a proper preparedness to the heat season this year. Thank you very much. And thank you to the speakers.
Thank you, everyone.